Welcome everyone, this is Dr. Thestrup, MD3, and today I'd like to discuss with you some of the physiology we're finding behind the COVID-19 pneumonias that are presenting to our hospitals around the country. Today I want to discuss two types of presentations of the COVID-19 pneumonia, or these hypoxemic patients that you may be seeing. I'm sure a handful of you have transported patients that are sitting in the 80% range and appear comfortable, that are in no distress, maybe a little tachypnic, a little short of breath. And I'm sure some of you could say, I've transported the same patient, but they were in extremis, they were tachypnic, they were hypoxic, and they just seemed like they were rapidly decompensating in front of me. So what we found, or what they found in hospitals around this country, and what they're kind of doing is labeling them as type L and type H patients. Now, it's still the COVID-19 virus. This isn't a different type of virus for one of these or the other, for the type L or type H. It just means that there are two presentations that they're noticing of this pneumonia with hypoxemia. So before we start, real quick, I wanted to go over a quick definition on lung compliance. I'm sure most of you remember this, but just to refresh your memory, lung compliance is a measure of the lung's ability to stretch and expand. So a sick lung, meaning pneumonia, or it has edema, has decreased compliance because it doesn't stretch or expand as easily. Whereas a normal lung can stretch and expand very readily because it's just, it's not infected, it doesn't have a lot of fluid in it, and it's essentially normal. So with these two presentations, let's first go over the type L. This is the patient that looks at you, they're fine, they look fine, except for their SATs are in the 80% range, maybe even the 70% range. They're able to speak to you, they're not in severe extremis. And what we're finding in those patients is that they have a near normal compliance, which means their lung actually expands quite normally. And what they're also finding is they have a normal amount of gas in the lung, or normal amount of oxygen in the lung for gas exchange. So for a lot of you, you're going to ask me, well, doc, that makes absolutely no sense. Why are they hypoxic if they have a normal amount of gas in their lung? Well, we're not 100% sure. Some believe there's a decoupling of the hemoglobin molecule, has something to play, ferritin plays a role in this somewhere, but we're not 100% sure at this point. Also, a lot of the theories behind this is cytokine response, but a lot of these patients with type L don't appear to be in this cytokine response. So I can't give you a definitive answer on that today, but I'm sure at some point in the future we'll have a better answer for you. And just keep in mind, all of this is rapidly changing and more evidence is coming out every day. We're learning more about this virus. So hopefully, as time goes on, we'll be able to provide some definitive evidence behind some of these findings. What we're also finding in these type L patients is they're the ones who may have a little bit of what's that called ground glass appearance on their CAT scan. They don't show this big whiteout of their lungs. They may show a little bit of a pneumonia. But overall, their CT of their lungs and their chest x-rays aren't terrible. So what about the type H patients, those patients that are rapidly decompensating? Well, what we find with them is that they have a low lung compliance. And a lot of that has to do with the fact that their lungs are filled with edema. So when their lungs are filled with edema, also you have a decreased gas volume that's available for oxygen exchange. So imagine this, you've got a lung that's filled with edema, you're trying to get this gas into it, but you still have those blood supply going to those alveolar sacs. Now, does everybody remember where the alveolar sacs are? Those are those tiny little sacs where the oxygen exchange occurs. It's where the oxygen comes in, transfuses through that, or diffuses through that membrane into that small capillary. That capillary takes in the oxygen and lets out the CO2, right? That's what happens on that alveolar level. But if that alveolar sac is filled with fluid, or infection, or edema, there's no way for that oxygen exchange to occur. So that's a problem. And a lot of these patients, they're the ones who have those scary looking CAT scans you see on TV, or the scary looking chest x-rays, and they look like they have what everybody's saying is ARDS. So these patients tend to be a little more sick and a little more concerning. So why am I telling you this? Well, for one, I wanted to explain to you why, or give you an idea that there are these two types of patients, because you're going to see them in the field. You're going to see them in the field at some point. The other thing is you may see a different response from the ER for these patients. So when we assess these patients that are hypoxic, our first thing we're going in our head is, do I need to intubate them now or do I need to intubate them later? Now, the type H patients who are in distress or appear to be rapidly decompensating, likely they're going to be intubated pretty quick when they arrive in the ER. Now, for the type L patients who may just be hypoxemic and not in that much distress, you may see us just try on an escalating protocol of oxygen. And what that may look like is I may first try a nasal cannula at 6 liters per minute. Then I may try a Venturi mask where I can actually adjust the FiO2, the amount of oxygen these patients are getting. If that doesn't work, I may move on to a non-rebreather. If that doesn't work, I may move on to a high-flow nasal cannula, which just means a lot more oxygen is going through that nasal cannula and able to oxygenate you a little better. And if that doesn't work and they start decompensating, then we may have to move on to intubation. I don't want to give the illusion that if you have type L, you can't progress to type H, because what they're finding is that some of these patients actually do, and they believe this may just be an evolution of disease. The other part of this, early on in the whole COVID pandemic, we were intubating these patients who were hypoxic and comfortable very early on because that's generally what we did, and we weren't used to seeing comfortable patients who are hypoxic. Well, putting someone on a mechanical ventilator, it can be quite damaging to their lungs, and with that damage can progress someone onto a type H patient as well. So that's why you're also seeing us try to withhold intubation if we can and try to keep them off ventilators. So next time you see these patients, you can kind of get an idea of what you're dealing with. I hope this does clarify some of the presentations of COVID with pneumonia hypoxemia that you will come across. Again, if you have any questions, please feel free to reach out to Medical Direction. We are happy to answer them. And again, thank you for your time. Take care.